Diabetic ketoacidosis is a common emergency condition. The patients usually present with signs and symptoms of nausea, vomiting, diarrhea, abdominal pain, dehydration, confusion, leading to altered state of consciousness. There is usually a past medical history of recent infection or any other comorbidity. New onset diabetes. Patients usually do not even know that they have diabetes until they land in the emergency with diabetic ketoacidosis, and it is usually type 1. Or they could have poor compliance to medications if they are already diagnosed with diabetes. So, whenever we have a patient with these symptoms and this history, we order two things: stat, finger stick glucose, and APGs, because these are going to tell us whether a patient has diabetic ketoacidosis or not. So, if our patient has a glucose value above 250 milligram per deciliter, a pH of less than 7.3, and a bicarb of less than 15, it is very likely that the patient has diabetic ketoacidosis and it is time to take action. As the metabolism shifts from glucose to fats, body starts producing ketones that appear in serum and later in urine. Although they are ordered as part of the initial investigations, they are not a part of diagnostic criteria and hence are not written over here. A rather more important value is anion gap, which is the difference between cations and anions. The majority of the extracellular cations are sodium, and the majority of the anions are chloride and bicarbs, and hence we take the difference of these, and the usual value is 12 if we do not include potassium, as we haven't in this equation, or if we include potassium over here, the value becomes 16. So with this equation, without potassium included, if the anion gap turns out to be greater than 12, it means that the patient could have a moderate or severe decay. I'm sorry, I'm holding my iPad the other way around. I'm really sorry about that. So, as the anion gap is greater than normal, 12 is normal and it is greater than 12, it is also known as high anion gap metabolic acidosis. So, it is one of the kinds of high metabolic acidosis. It is important to distinguish DKA from HHS. As you can see, HHS has a blood sugar of greater than 600, and DKA, even if it is severe, the blood sugar limit, the lower limit is 250. Moreover, the pH in HHS is greater than 7.3 and it is less than 7.5 or 7.3 in DKA, and it can even be less than 7 in case of severe DKA. Patients do not go into stupor or coma unless the patient has a very severe form of DKA. But in HHS here, they are usually going to present with stupor and coma more often than DKA. The amount of serum ketone is lower and serum bicarbonate is greater in HHS when we compare to DKA. So here we just discussed the general picture of diabetic ketoacidosis. How does it look like in the labs and what do we have to look for? Although as part of the initial diagnostic criteria, the lower limit of glucose has to be 250 milligram per deciliter. So The patients with DKA usually present with a glucose greater than 250. However, sometimes the patient may present with euglycemic diabetic ketoacidosis, meaning that they have normal glucose values, and there are certain cases in which it can occur. First of all, they have a poor oral intake, maybe because of nausea, vomiting. They are not taking enough glucose already, so their body is not having high glucose. Or they just infused with themselves with insulin before coming to the hospital, so that they do not have a bad reputation with the doctor. Or it can happen with pregnant patients, women obviously, as their glucose is always being used up by the fetus. Or it can happen with the patients who are on oral hypoglycemics called sodium glucose cotransporter 2 inhibitors, SGLT2 inhibitors. They work by excreting glucose in the urine, hence, it leads to normoglycemia. Some of the examples of these drugs are canagliflozin or dapagliflozin. So these gliflozins are SGLT2 inhibitors. As previously discussed, the neurological symptoms appear more in HHS as compared to DKA. Why? Because in HHS, glucose is higher than DKA. So if the patient has severe DKA, their osmolality is usually greater than 320 to 330. And it is with this osmolality that the patients may present with stupor or coma. But the presence of stupor or coma in diabetic patients with an effective plasma osmolality below 320 demands immediate consideration of other causes of the mental status change. Effective plasma osmolality can be calculated as 2 times sodium plus the glucose divided by 18. Patients with euglycemic diabetic ketoacidosis generally require both insulin and glucose to reverse ketoacidosis. As the patients in DKA usually present with abdominal symptoms, so they are also, as part of the investigation, they also have amylase and lipase levels ordered. But interestingly, they're elevated in 10 to 15 to 20% of the patients with DKA, and it does not mean that the patient has acute pancreatitis. As hyperglycemia can lead to pseudohyponatremia, it is important to calculate corrected plasma sodium in some cases that it may appear to be low. So you can calculate it with measured plasma or serum concentration plus 2 times serum glucose minus 10 over 100. Let's move on to the treatment part, the most important part. So we have seen the patient has problems. The patient has dehydration. The patient has increase in glucose. The patient has acidic pH. And the patient might also have an ongoing infection. So we are going to address all of this. The deficit is usually 4 to 5 liters, and we usually give the normal saline over first 2 hours, and then at the rate of 250 to 500 ml per hour until that deficit is overcome. We usually give us half normal saline when serum sodium concentration is above 150 milliequivalent per liter. It is very important to get potassium levels before you actually start the infusion. Do not start a crazy infusion unless you have this potassium in hand, because what happens is that insulin drives all the potassium inside the cell, leading to hypokalemia, which can trigger severe arrhythmias. And these arrhythmias, along with dehydration and static position of the patient, can lead to DVT and MI or stroke. The normal value for potassium is 3.5 to 5. And when the potassium is less than 3.5, we do not give insulin no matter how much high the glucose is. Fluid replacement helps dehydration as well as it helps overcome some of hyperglycemia. So the rate of infusion is usually, in the absence of contraindication obviously, is zero point 0.1 units per kilogram per hour, preceded by a bolus of zero point 0.1 units per kg, or a continuous infusion of 0.14 units per kg only. As part of management plan, it is important to make a chart that has BSR, potassium, ABGs, as well as that keeps a record for input and output from the patient. It is expected from glucose to fall by at least 50 to 70 milligram per deciliter in the first 2 hours. So if it doesn't, what do? We double the rate of infusion. If the glucose does not fall by 50 to 70 milligram per deciliter after first 2 hours, or what else can we do? We can repeat a loading dose of 0.1 or 0.14 units per kilograms. If we do not have an infusion pump, what can we do? We can give insulin IM. So in that case, an initial loading dose of 0.15 units per kilogram of regular insulin, and at the same time 0.15 units per kilogram of IM insulin is given. Subsequently, a regular dose of zero point 0.1 units per kilogram per hour can be given intramuscularly until the glucose falls to around 250 milligram per deciliter, when zero point 0.1 units per kilogram can be given subcutaneously. So basically, in case of IM regime, you do not shift to subcutaneous insulin unless the glucose has fallen below 250 milligram per deciliter. The insulin that we usually use for DKA is regular insulin. And if the patient is already on glargine or detamir, then the regular dose can be continued during the initial treatment of DKA, along with the regular insulin. One very important aspect of treatment is potassium. So when do we replace potassium? We do not replace potassium when it is greater than 5.3 milliequivalents per liter. At levels below 3.3 milliequivalent per liter, we usually replace potassium at the rate of 20 to 40 milliequivalents per hour, which usually requires 20 to 40 milliequivalent per liter added to saline, that is usually 2 ampules. When the potassium is between the limits, that is between 3.3 and 5.3, we usually give 20 to 30 milliequivalent per liter to each IV replacement, that is 1 ampule is added per liter of the solution until the serum potassium concentration has increased to 4 to 5 milliequivalent per liter range. Then we can stop giving them the potassium. It is important to note that we can also give oral therapy for potassium, and in every ampule of potassium there are usually 20 to 25 milliequivalents of potassium. A glass of tomato juice of 240 ml will contain 14 milliequivalents of potassium, and a medium sized banana can have 10 milliequivalents of potassium. We do not replace bicarbonate until it has dropped below 6.9, and in that case we can add 100 milliequivalents of bicarbonate in 400 ml of normal saline and give that to the patient. Transition to subcutaneous insulin is very important prior to discharge, and it is important to note that if the patient has been taking any insulin prior to admission, the same dose can be restarted in the hospital in order to see how is it going, and you can change or titrate the dose accordingly. Insulin naive patients who have never had insulin before, they require insulin at a total dose of zero point 0.5 to zero point 0.8 units per kg per day, divided as 50% basal and 50% prandial insulin before each meal. So, besides basal bolus regimens, we also have options for long acting insulins like glargine. That depends totally upon the patient's affordability and his commitment to use the particular insulin.